Good afternoon, everyone. My name is Susan Manahan. I'll be moderating the session today, which is addressing evidence-based and practical strategies during the administration of cognitive tests to individuals living with dual sensory impairment. So I'd like to introduce Shirley Dumasse, who is a research agent in the Wittich Vision Impairment Research Laboratory at the University of Montreal. She is also a research trainee on Team 17 of the Canadian Consortium on Neurodegeneration and Aging, specializing in sensory and cognitive aging. Her research focuses on optimizing the professional administration of cognitive tests to individuals living with sensory impairment using a knowledge transfer and exchange approach. She obtained a Bachelor of Arts degree in psychology from Concordia University and also completed a Master of Science in Vision Science at the University of Montreal in Quebec, Canada. Her research interests include cognition, cognitive evaluation, dual sensory impairment, hearing impairment, knowledge transfer and exchange, and vision impairment. So please welcome Shirley.
Hello, everyone, and thank you for coming to my talk. I'm really honored to be sharing this moment with you, where I will really be sharing any of the research that I've done as part of my master's and how I want to move forward with my research interest. So thank you for the great introduction. I even prepared a slide, but I think the introduction earlier summarizes really well. I'm 27 years old, and like you mentioned, my interests really lie into anything that is related to sensory impairment, cognitive impairment, and also aging. So today, as my title had suggested, I'm really interested in learning about the links between sensory impairment and cognitive impairment and aging. And that is because we know that right now one of the growing concerns as our population is aging is cognitive decline. And with cognitive decline, there is a higher risk as well of developing sensory impairment, both hearing and vision impairment. There are both modifiable risk factors for developing cognitive decline over time. So we know that it is important to consider as well this link between the sensory impairment and the cognitive impairment of an individual over time. There's also a lot of scientific evidence that really suggests that there is a link between sensory and cognitive impairment, because people, when they perform cognitive tests, they tend to have lower scores on the measure that they will be performing. And although there's plenty of evidence in the scientific literature demonstrating this, we have to take it with a little bit of a grain of salt, because this link is not as clear as we think it may be. It is possible that when we are conducting cognitive tests with people that have sensory impairment, the cognitive decline or just their cognitive health is not accurately being depicted with the test. And that is really solely based on the fact that the test that we use, like the Montreal Cognitive Assessment or the Mini Mental State Examination, really will assume that you have functional vision and functional hearing to be performing them. They are presenting visual items, they're asking you to listen to instructions, so they are really assuming this function of your sensory health when performing these tests. But that is not the case when someone is presenting with sensory impairment, whether it be just vision, just hearing, or both at the same time. So there is this risk of overdiagnosing cognitive decline in someone that has sensory impairment just because the person is not performing the test to the best of their cognitive abilities, and it's not as accurate of a measurement as it could be, and that can in turn influence any clinical judgments or any inferences, whether in a research or in a clinical world, that a person makes. So now, what I was interested in is, how do we address this then? So what do we do? It seems we're kind of stuck now because the tests that we're using rely heavily on the fact that you have a visual function or hearing function that is functional. So how do we address this? And I'm happy to show you what we've been doing in order to do this and what we want to be doing. So how we have conducted many research projects that have many phases that I'll happily outline for you today. Where we first wanted to start, so as researchers, we wanted to stay within our own field and see what have researchers been doing in order to accommodate any participants in their research studies, in order to make sure that when they would be administering these cognitive tests, they are accommodating for that sensory impairment. So in order to do this, we conducted a scoping review of the literature to really see which were the different, call them adaptations, strategies, modifications, alterations. At this point, we were exploring, so we did not know exactly what would be, but any action that was taken in order to make sure that the participants with sensory impairment would be accommodated in order to perform these tests. So we ran a scoping. We explored 7 databases of scientific literature, and we read a lot of articles in order to capture articles that would really be looking at 3 main ideas. So we wanted articles that look at the aspect of cognitive evaluation. So any tool, any measure that is used to either screen global cognition or different cognitive domains. We also focused on dual sensory impairment, so in this case, vision and hearing impairment, because this is where we think that there's a complexity to this condition that also is important to focus on. And we focused as well on older adults because they are more vulnerable given their aging status. After looking at all these articles, a total of 67 articles were retained in order to be analyzed within our study. And out of these 67 articles, less than half of them reported any type of action in order to accommodate for their participants. So 28 out of the 67 did anything or something in order to just have this little piece of rigor in their protocol. The most reported adaptation would be to have in your team of research an expert that would be external to your project in order to kind of help you during the administration of these tests or the evaluation of the results or interpreting all of the results that you've gained. Such experts could be like a trained research assistant or a dietitian, a neuropsychologist, just someone that would be external to your research project in order to just help you in validating kind of the cognitive status and taking into consideration the sensory profile of your participants as well. So 18 studies did that, and that was the most reported adaptation. 6 other studies, so there's already a big decrease on how many studies used any type of strategy. So the next most reported was only reported in 6 studies, and that was using cognitive tools that do not present any visual items or any auditory items or any of the visual or auditory items. So an example of this would be the telephone interview for cognitive status, which was designed to be administered remotely, so it doesn't present any visual item to the individual. There were also reports of a tactile test battery. So the participants were conducting the test and performing the test without the use of vision or hearing. It was really all done manually. 4 studies would use cognitive tests that are already commonly used, like I mentioned, the Montreal Cognitive Assessment or the Mini Mental State Examination. And these exist in the blind version. So in the blind versions, you would just remove the items that are completed visually, such as the visual spatial tasks, and you would just adjust the scoring of the end results by removing any points that would be allocated to these items. So 4 studies use these tests. So 2 use the MoCA blind and 2 use the MMSC blind. Another 4 studies would use communication strategies, such as making sure that you're speaking at a proper tone and clear tone and loud enough for the person in order to enhance audibility. Environmental strategies were the least reported one, with only 2 studies making use of them, and that would only be by controlling the noise level in the room during the cognitive administration test. So now, this is what researchers do. In our phase 2, we're now wondering, is that what is actually being conducted in the clinic and practice? We know what is being done in research. Does that translate into the clinic? So after learning what researchers are doing, we are wondering, are clinicians even aware of the different types of adaptations or accommodations that are being reported? Are they the same that will be identified in the literature? So we wanted to go into the field and ask clinicians what it is that they are doing in order to accommodate the cognitive screening or the evaluation of their clients. And to do that, we conducted and we distributed a practice survey to clinicians. And we started with the profession of occupational therapy. And why occupational therapy, you may wonder. So we had to start somewhere. We couldn't start everywhere. It would be there's a lot of healthcare practitioners. So we started with occupational therapy. They had demonstrated the most interest in our research question. And also because as they are responsible for creating intervention plans for people that may have different disabilities and conditions, they sometimes have to administer cognitive screening tests just to be able to know all of the to have a well-rounded picture of their client and to assess their needs to the best of their abilities as well. So they will sometimes administer cognitive tests to their clients. So what we did is we recruited occupational therapists from Canada, and they were recruited through the professional orders, and then we just sent out a survey. And in this survey, we just wanted to get firsthand experience of them administering cognitive tests to their clients. We wanted to know what they are doing and how they feel while doing it. Is it something that's even an issue for them? Is that something they would like to learn more about? Or are they feeling like they have enough resources to conduct this? So a total of 87 occupational therapists, I will refer to them as OTs, so I'm just using that to make it a bit shorter, and a total of 87 of them have responded to our survey, 66 from Quebec and 21 from Ontario. And I think it's really important to note that 40% of them had more than 20 years of experience. So we had information from people that have been working in the field for a long time and could have gained just real life experience with the matter. So when we first asked them, so please rate your satisfaction with your own ability to deliver services to people that have sensory impairment. And in order to compare how it may differ depending on the condition, we first asked them to rate their ability when they are faced with clients that only have vision impairment, with clients who only have hearing impairment, and then to see how it would differ for for clients that have dual sensory impairment or deaf blindness. So for visual impairment and hearing impairment, it is fairly similar. There's no statistical difference between the two. But as soon as we ask them about their clients living with dual sensory impairment, that's where we see a downward shift. Like their self-rated ability completely goes down. Well, it goes down as compared to an average of 3 on 5, 1 being completely unsatisfied and 5 being completely satisfied with their own service delivery. Vision and hearing are about 3 on 5, and when it comes to dual sensory impairment, it decreases to 2.34 on 5. So they definitely feel like they're not as equipped, or they don't feel as comfortable providing services to people who have dual sensory impairment. So we see that even this condition can change and have an influence on the provision of healthcare in this context as well. And when we ask them which tests they use during their cognitive test administration, the MoCA, the Montreal Cognitive Assessment, and the Mini Mental State Examination were the mostly reported ones. And that is, mostly they are global cognition tests, so it is easily accessible and is very commonly used, but they also reported the use of other tools such as self-report or the clinical dementia rating, but the MoCA and the MMSE were mostly the ones that are reported the most. And then when we asked them to identify the different accommodations that they implement while they are conducting these tests with these different populations, we see that there's, I'm going to outline the different identified strategies, and you can see that there's going to be different patterns. So we first asked them what are the adaptations that they use with their clients that only have visual impairment. The most reported one would be to just encourage their clients to wear their visual aids or any assistive technology that may aid them during the procedure. Or they would just make sure that the lighting is adequate in the room for them to do so. And the third mostly reported one was to just have some type of awareness as to what the visual function of their client may be by just screening it beforehand. So whether it be by subjectively asking them how they would rate or how they would quote quantify or just identify their visual function, or it would be with an objective assessment such as visual acuity. When we ask them how they accommodate for the test administration of their clients who have hearing impairment, but more specifically who are hard of hearing and still use spoken communication, again, they will encourage the use of hearing aid. Then they would ensure that the environment is quiet enough for the test to be conducted in a noiseless environment to make sure that the person can hear to the best of their abilities. And they would also ensure that they're speaking at a pace that is as appropriate to them or as audible to the person in front of them. Now, things change when we ask them about the accommodations for their clients who are deaf and who use sign language. So in that case, the most reported adaptation would to ensure that there's face-to-face communication during the interaction, to make sure that, again, if they are wearing any type of hearing aid or any other assistive technology, that they are wearing it, and that would be the second mostly reported one. And speech adaptation as well would have been the third more reported accommodation. And when it comes to their clients living with dual sensory impairment, the same pattern is there. We encourage our clients to wear any assistive technology that may facilitate the process for them. And then we want to make sure that we have some idea of the level of their hearing or visual impairment, so subjectively or objectively screening for their sensory function beforehand. And we want to make sure that if they don't have this assistive technology, we are providing it to them. So that was the thoroughly reported strategy by OTs. They would provide any assistive technology to their client if they have it available. So then, what do we do now? So we got this information. It was a quick survey online. It was 5 to 10 minutes to really just gather this information, and they were really just identifying the different strategies that they use. However, we were not provided with a lot of context to their answers. So it really helped us in getting information about what is the difference between what's going on in research and what's going on in the clinic. So we identified that there's kind of a knowledge to practice gap, but it's not enough now for us to address it. So we need to learn more about it. And in order to learn more about it, we decided to conduct interviews in focus group with occupational therapists again, so they can provide us with some context and some nuances and really provide us with more specific information to learn more about this issue. So we conducted these interviews again with occupational therapists. They were recruited in the same manner as for the survey. And they're being conducted right now. So this is where we are standing now. And as of right now, we have already conducted this. There were 3 at the time that I submitted the slides, but we're now at 4. And they're all from Ontario at the moment. And I'm going to present some preliminary insight on what came up on these interviews. And just to let you know that although they have all been practicing for 10 years, all of the OTs that were recruited did not have any type of training when it comes to providing services to people that have sensory impairment. So that is also something to have in the back of your mind when you're listening to what they have identified. So there are many factors that were brought up that were either just neutral factors that were positive or that were a little bit more negative in trying to either facilitate or just limiting the administration of cognitive tests to their clients. One of the big ones in occupational therapy is that the cognitive test itself is an indicator of some information, but as OTs, they will usually conduct complementary assessments. To them, the cognitive test is one type of information, but they will often supplement this with other tests, whether it be functional tests or others, psychosocial tests. Often it is rare that they would only conduct a screening test of their cognition and just leave it at that. So they really take the answers from every different test, and that is what helps them in making their clinical judgment. Also, the clientele that they are working with will also have a big impact on how they are approaching their cognitive screening. For example, if that OT is really specializing in driver rehabilitation, their interest in global cognition is not the same. They will probably focus on specific cognitive domain, but not global cognition, because it's not their interest in order to make a decision as to whether or not someone could or should keep driving or have their license revoked. The practice institution as well will also determine, can also have an impact on how this goes. For example, the resources that are available in a certain institution, and also whether it is a referral institution or in a in-house institution as well, so that can have an impact on how this all goes. There's also factors that are limiting cognitive administration, and that is if there's no assistive technology available for the person to provide to the client, that is also something that is limiting to them, and they don't know what to do. They can't really help their client more than that if they don't have the resources to do so. And if they don't know the sensory function of their client beforehand, because it wasn't a referral, it's just someone who decided that their parent would need the help of the occupational therapist, so they don't have their whole health file with them beforehand, that is also something that can be limiting, or can be something that they would like to have in order to facilitate their session. But there's also facilitating factors. So on the reverse, if you do have access to the medical file of your client beforehand, it helps you in trying to prepare the cognitive test administration. And also, if you do have access to pocket talkers or any magnification tools, that will also help you. And then what do we do with all this information? So where would we go from there? Whenever we're done with accumulating all of this evidence from the research, from the surveys, as well as from the interviews, well, our goal is to gather all of this information and to build on it to now develop educational materials. So this is how we are hoping to address this issue and bridging that knowledge to practice gap. So to do so, we will create, right now we're still in the creative stages of this, so it's still up for discussion, but we want to create different types of educational resources that can be sent back to clinicians in order to equip them with just more knowledge, with more tools, with guidelines maybe, or just tips in order to optimize when they are conducting cognitive tests to their clients. This can be videos. Right now we're thinking videos, maybe one video that's 50-minute long, maybe 5 videos that are 10 minutes long. This is variable, and this is also why we're conducting these interviews, because we're kind of getting a little bit of an idea of what the OTs would like to know more about their practice, what is missing, how can we address this, and we're getting just an idea of what would be best to just transfer information back to them in a way that it would be well received and accepted by them as well. So we're currently in the stages of brainstorming for these little resources, but right now we're looking at topics that would explore just the risk factors of cognitive impairment, of sensory impairment, communication strategies, technology, environmental strategies as well, and probably more. And of course, I say we because I'm not alone in doing this. So as mentioned in my introduction, I am part of the Canadian Consortium of Neurodegeneration and Aging. And as part of our team, which is Team 17, we have a lot of experts in anything that has to do with neurodegenerative diseases, sensory impairment, comorbidities, cognitive impairment, and aging. That includes a speech-language pathologist, a neuropsychologist, vision rehab specialist, many more SLPs as well. So we have a well-rounded team of experts who are working together in making sure that these materials are as comprehensive and accessible to our clinicians. And we also have an occupational therapist on the team developing these materials with us, because we want to make sure that we have their insight throughout this process, and we know that we're targeting whatever is needed in current practice for occupational therapists. But most importantly, we also have 4 individuals with lived experience of dementia on our team. So we have a voice of the people that we're targeting, people who are at risk of developing cognitive decline. They are people that have either dementia or the caregiver of someone. So they are also part of our team, and they're following us along this journey of developing these materials. And after that, whenever everything is ready to go and the materials are created, we will learn a little bit more about the educational side of this project. So we're going to learn about how to best reach out to clinicians as researchers in order to kind of bridge, again, this knowledge to practice gap and return back information from our research studies in a way that will be well received by them. So we will ask them to evaluate the different materials that we have transferred to them. And we will do that so that before they get the information, all of the educational resources, we will ask them questions about their knowledge of the issue at hand, about their attitudes, about their practices, before they get the information from us. And then after they've completed they've viewed all of our educational materials, we will then ask them again the same question to see if there was a shift there. And we will also ask it 6 months after, because we want to know if the knowledge even persisted in time. But there will also be a part where we ask them to evaluate us in the way that we presented the information to them. Was it relevant? Was it interesting? Did you already know this? Did you find any use to it? If not, what could be done better? And with that information, we can really refine the way that us researchers try to communicate with clinicians and transferring information that may be relevant to us. So that's it for me. So thank you so much for attending, and I'm happy to answer any questions that you have.
Any questions? Don't be shy. Oh, over here.
Hi, Anne-Marie Rotherham from, I've forgotten where I'm from, I'm so jet lagged, Sydney, Australia. I'm a medical doctor in the past, and this issue with particularly the mini mental state and clinicians, especially doctors, is really significant in perpetuating the wrong diagnosis, and our changeover to electronic health records has meant that it's extremely difficult to get that erroneous result and diagnosis taken off. And I always thought this was an exceedingly academic kind of issue until I had a really bad asthma attack, ended up in ICU, and they did a mini mental state on me without, well, I didn't even realise they were doing it for starters. And they told my husband that I had significant cognitive impairment because I didn't even know who the Prime Minister was. And I mean, our Prime Ministers at that time were changing fairly frequently, but I did know that we'd had 4 in 5 years. But my husband just went, well, did you have a hearing aids on? Did you have the blinds down? Did you use the big black texture and a whiteboard? Mm-hmm. You know, how did you do this test? Mm-hmm. So, and then in my own research, which was on hospital experiences, we saw quite a number of people reporting that they'd been given many mental states and had performed poorly, and it took sometimes one person took about 2 months to have it unravelled that the whole thing was wrong, and others were able to sort it out within days. So I think it's a really significant problem, and we've started making a video showing 2 examples of, you know, what can go wrong and how to fix it. Great work.
Thank you.
It's definitely really needed among clinicians.
Yeah. hopefully, we're hoping whenever we get the results from our occupational therapist, the ultimate goal would really be to expand to other professions. Right now, we're focusing with them because they have they have really specific responsibilities and they have a specific role in rehab. But if this proves to have been useful for them, then we can work on adapting them to different professions, such as general practitioners. So this will be the ultimate goal, to then be able to reach a number of professions in healthcare. Hopefully, yeah.
One more over here.
Thank you. It's Karen from Australia here, West Australia. Just a slight diversion, but I'm really interested in the younger population of people with dual sensory loss. Just to quote one experience, a young gentleman who was going through the justice system and was, as Anne-Marie mentioned, was labelled as cognitively impaired, which he is not. But all those complications of the delayed learning, etc., literacy, etc., 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 but he carried that label throughout that system and then has carried on in exactly as Anne-Marie suggested in other systems. So I'm curious, is there plans for work on these types of assessments for younger people with dual sensory loss?
Not at the moment, but that's definitely something that will be important to look at later on. So right now we're really just kind of growing. So we're starting with a small profession with specifically screening and not like a complete neuropsychological assessment, because we're not neuropsychologists and they have their own expertise when it comes to the topic. I think eventually, yes, right now it's morely for acquired maybe, because there's one sense that may be able to compensate for some of these adaptations or not, depending on the severity. I think eventually youth would be one of the future directions to definitely look at when it comes to screening and cognitive evaluation. Yeah, thank you.
Hi everyone, my name is Amy. I'm a sign language interpreter from here in Canada. I have had the pleasure of interpreting some of cognitive testing of different varieties. And the one thing that I find most challenging about the testing is the fact that I have to be the expert as much as you are in order to facilitate the testing on your behalf. So getting that information in advance, understanding the purpose of the testing, what you're trying to get out of it, because it significantly impacts how we translate that information to get you what you need, as much as to give them what they need to do the task at hand. So for example, some things you're asking a direct question, but when you interpret it, I can't give them the answer by accident, because sign language, you have to give the point in a different way, and there's a different sentence structure. So it depends on different pieces of information. So being able to include your service providers, like interpreters, interveners, etc., in the preparation for the testing, or even do a consultation of some sort so that everyone knows what to expect. And if you have to make adaptations like pre-screenings and things like that, you can get a sense of this person's communication style before you administer the actual testing, giving both you and the participants time to adjust and adapt accordingly. So that was just one thing I wanted to put out, since most of the folks, I believe, are practitioners that are of a different profession. Thank you.
Thank you.
Sure.
Thank you for this point. The team that has developed the Montreal Cognitive Assessment, we've been trying for years to get a grant to validate a sign language version of the MOCA. Because, like you say, it needs to be structured differently so you don't give the answer as you ask the question. And it's a great example of something that is important for the field, but that we have not been able to fund, because it's difficult to justify. It's a big expense to do this. It needs lots of people and lots of different professions. And I'm optimistic we will get it done, but it's a challenge.
Anyone else? Oh, yes.
So it's Amy again. And since we've most recently passed the Accessible Canada Act, in Ontario we have the AODA, it's becoming more required to be able to provide those things because American Sign Language, Langue des Signes Québécois, and Indigenous Sign Languages are much more recognized and officially accepted as the languages of the deaf community, at least in Ontario and Canada. So that might be an element that we can use to push for that access. And even just to the point of how can you expect someone to do a test in a language they don't use? It's just like if I went to Germany, I know next to nothing in German, and then saying, here's this cognitive test. Of course my result will be impaired because I don't know what you're saying. But it's not because I don't understand the content, it's because I don't understand the words themselves to gain access to that content. So it's comical that we expect people to do testing in a language they don't have access to in the first place.
All right, anything else from anyone? Those were great points. All right, well, I'll just hop back up here and formally thank Shirley for a great discussion. So we're at the point now where we are coming up to a 30-minute break. We'll be reconvening at 3:45 up in the third floor. Make sure that you check out the exhibitors, and the Group C poster presentations will also be up. And Shirley, on behalf of DBI, we just wanted to give you a little token gift.
Thank you so much.
Thank you very much. Enjoy your afternoon.
Thank you.